All right, good afternoon. Thank you for joining us at the Boston Globe's Future of Medicine Summit. I'm Shirley Leung. I'm a Globe columnist, host of the Globe's Say More podcast, and one of a growing number of people under 55 who've had cancer and survived. I told my story and others in a 4-part series on Say More. Find it wherever you listen to podcasts. This panel, The New Face of Cancer, looks at the alarming rate in cancer among adults under 55 and what it means for prevention, diagnosis, treatment, and long-term survivorship. We're covering it all, of course, and here to help us understand what's going on are Dr. Kimmy Ng in the middle. She's the founding director of the Young Onset Colorectal Cancer Center at Dana-Farber Cancer Institute. Here we have, and next to me is Dr. Trisha Pasricha. She's director of the Gut Brain Institute at Beth Israel Deaconess Medical Center and the Ask a Doctor columnist for the Washington Post. She's got great poop videos on TikTok, by the way. They're all GI specialists, so it's comes with the profession. And then lastly but not least is Dr. Shuji Ogino. He's Chief of Molecular Pathological Epidemiology Program at Brigham and Women's Hospital. He had a very short 5-minute walk here. He also teaches at Harvard Medical School and the Chan School of Public Health. Our panel will conclude with closing remarks from Dr. Raj Hazarika. He's Chief Medical Officer for Commercial Products at Point32Health, the parent company of Harvard Pilgrim Health Care. So I have a few questions, but those of you who've been here, you can also ask questions here as well. I think there's a QR code, and I'll work them into our conversation today. So you mind if I call you guys by your first names? So Kimmy, let's start off. You started one of the first clinics in the country focused on young onset colorectal cancer. What trends made you think this is necessary?
So I have been caring for patients with colorectal cancer for 20 years now at Dana-Farber, and I would say that in each consecutive year, my colleagues and I started seeing increasing numbers of very young patients, no risk factors, no genetic condition, and no family history coming in diagnosed with very advanced stages of colorectal cancer. And where anecdotal data turned into published evidence was through a paper published in 2017 that formally documented that colorectal cancer has been rising in both men and women by about 2 to 3% per year since the mid-1990s. And this is something that's not just happening in the US, it's actually a global phenomenon. And what's even more frightening is that colorectal cancer is now the leading cause of cancer-related death in men under the age of 50, and the second leading cause for women, and expected to become the leading cause in young women by the year 2030. So with the increasing numbers of people being diagnosed, we felt it was necessary to start a dedicated center to take better care of young patients facing this illness, and also to launch a multidisciplinary research effort to really understand why this was happening.
I mean, just to put it in this context, you just started this in 2019, right?
Yes, and we were probably one of the first to start in the country, and now there are centers similar to ours to help better take care of these young colorectal cancer patients all over the country, which is a great thing.
I mean, Trisha, are we seeing, what about other kinds of cancers? Are we seeing a rise beyond colorectal?
Yeah, since 2000, cancer rates for patients aged 15 to 49, so younger people, they've been rising by about 10%. So this year, 200,000 young people are going to be diagnosed with cancer. Millennials are among the hardest hit. Women tend to be diagnosed with cancer at rates that are 83% greater than men in that younger age category. Now, we should be clear, the younger cases, they're not the majority of cancer cases. The older age is still the most important risk factor for cancer, but the trend is worrisome. So for 17 of the 34 most common cancers, we're seeing that trend in rise in early onset cases. So breast cancer, thyroid cancer, kidney cancer. We're seeing a worrisome trend, and we need to sort of help figure out what is going on with the help of these kinds of centers that are dedicated to researching, understanding, and treating it.
And Trisha, let's stay on this topic because, I mean, when I think about the rise of cancer in younger patients, I mean, how much of it is just due to better detection and awareness versus an actual rise?
Yeah, that's the most common question I think people get when they look at this data. And the short answer is that it appears to be a very real trend, and it's not explained entirely by better screening. And in fact, if we're being honest, we're not doing so hot when it comes to screening for a lot of these cases, right? So if we look at colorectal cancer, for patients aged 45 to 49, only about 20% are up to date with their colorectal cancer screening. For women aged 60 and older, only 66% are up to date. And for a lot of these cancers that younger people are getting, they either are getting it before they would be eligible for screening, or they're getting kinds of cancers for which we do not have screening. So there's a lot of work that we need to do to increase the uptake of the screening that we do have, but also to increase awareness of what the symptoms are and early detection in general.
Shuji, your specialty is studying the pathology,
Yes.
right,
Uh-huh.
of at the molecular level,
Mhm.
and is the cancer we're seeing in younger patients, is it different from other cancers in older patients?
I mean, there are overlaps with younger patients and older patients. The molecular changes and pathological changes, but there are features specifically more common in younger patients, and then those are in colorectal cancer, for example, those are more aggressive features. So that actually go against the theory of early detection only, that's actually proving this is a biological phenomena. So the young patients are getting aggressive cancer, and they have a higher mortality, higher stage at the detection. So that cannot be explained by screening and early detection alone.
So how does that change, treatment, and when you're seeing a different kind of cancer in younger patients?
So right now, because we haven't pinpointed a consistent biological difference between the cancers that happen in younger people versus the cancers that happen in older people, the medical treatment is actually exactly the same, but with two important distinctions. One, every young patient diagnosed with cancer should undergo hereditary genetic testing, because even though most of these cancers are not due to genetics or family history, it is more common to find a genetic syndrome the younger you're diagnosed. And then the second is that younger patients face unique challenges when they're diagnosed with colorectal cancer at that age. And so things like fertility preservation and really making sure that patients are being counseled about that before treatment starts is really important. There are also high rates of psychosocial distress. Over 80% of our young patients with colorectal cancer have children under the age of 18. They're taking care of elderly parents. They're still working. There are a lot of disruptions that need to be addressed.
I mean, one of the things, so when I had my cancer, I had breast cancer when I was 45, and as a result, they were like, well, you're probably more prone to colon cancer. So I had my first colonoscopy at 45, but since then, I mean, my cancer was in 2017, 2018 now. So since then, they've actually lowered the age, right, for screening. And so talk about that. I mean, why was that done? And what have been the results of lowering the colonoscopy recommendation from 50 to 45?
Yeah, so the American Cancer Society was the first society that actually recommended changing the screening age down to 45 back in 2018. And the United States Preventive Services Task Force followed in 2021 with this official recommendation. As Tricia said, though, only about 20% of people 45 to 49 are getting screened right now. But in a recent paper published in JAMA, there was some good news in that more early stage cancers are now being found and diagnosed in people between the ages of 45 to 49. And I do think that's a direct result of these changes in the screening age that have been implemented.
We have a good question from the audience here. When thinking about screening, what's the biggest hurdle you see in like preventing widespread adoption? Like, why aren't more people? I assume the insurance is covering it, right? So why isn't there more widespread adoption?
That's a million, if not billion-dollar question, but I can start, but please jump in. But I think so insurance companies will cover now at the screening age of 45. So if you're eligible, please do get the screening. That shouldn't be a barrier. But there's a couple of things. Like one, colonoscopy, it's a very safe procedure. We do, here in these hospitals alone, thousands every year. However, It's not the easiest procedure for people because you kind of have to take half a day off from work. You need someone else to drive you home if you get sedation. These might sound simple. They're not simple for a lot of people. And then the prep feels really daunting. Let me tell you, the prep today is not your grandfather's prep, okay? It is much easier than it used to be. It's small volume. You can mix a lot of like sort of additives in there so it tastes great. We can talk more about this offline. But
She's very good at talking about poop prep.
the prep shouldn't be a barrier, but it is in a lot of cases because you're sort of tied to the body. So the colonoscopy, it's easy, straightforward, but there are some barriers. Now, there are alternatives that I think people are a little bit less aware of, and those will count towards like technically being screened. And I think we need to do a better job about making people aware of what those alternatives are. So those are things like FIT testing or stool kit testing. You can get a CT colography, which is a virtual colonoscopy. You still have to do the bowel prep, but you don't have to come in for a procedure. So there are alternatives if you're eligible, if your loved one is eligible. Talk to their provider about what those alternatives are and what your concerns about it are. And I think if you have a conversation with your provider, your gastroenterologist, your loved one, you might find that the barriers you're perceiving are actually not as maybe insurmountable as they might have felt a few decades ago.
May I say something? So I think the biggest hurdle is people don't think of cancer until you get it. I think that's the biggest hurdle. I think we have to change the way of thinking. I think every one of us have a pre-cancer in our body because we now know every one of us, every cell actually have some mutations, a cancer driver mutation in our body. And I think we don't know when they start, but we can even detect in babies or fetuses even. So I think now the boundary between normal cancer, pre-cancer is very broad. So basically, every one of us have a risk factor, cancer driving mutations. Then we can go for more screening, right?
We shouldn't be afraid.
And the tumor develop over decades. So that's the most challenge because we don't think of cancer until we get it.
I mean, let's talk about causes. I mean, we have a bunch of questions from the audience about that. I mean, besides genetic, predisposal to cancer, what about lifestyle? What about the environment, especially if we're seeing a rise of colorectal cancer globally?
Yeah, so the trends, if you examine them closely, follow what we call a birth cohort effect, where the increase is rising by generation. So to really illustrate that point, somebody born in 1990 now has quadruple the risk of developing rectal cancer and over double the risk of developing colon cancer compared to a similarly aged person who was born in 1950. And when we see this generational variation in incidence, it usually points to environmental exposures that have happened recently as the likely contributors to why these trends are being seen. And so things like diet and lifestyle, poor quality diets, obesity, sedentary behavior have all been linked to an increased risk of developing colorectal cancer at a young age. However, I can tell you, my colleagues and I see patients who are triathletes, marathon runners, who are very healthy and eat organic, and they develop stage 4 colorectal cancer. So there is something else going on, and that needs further research.
We have some more good questions from the audience here, and I was thinking about this too. We're talking about, Kimmy, and you talked about how you're suddenly seeing all these patients, right? And that's why you started your early onset colorectal cancer clinic. So, what are the type of symptoms that you're seeing that make people come in and said, I need to get checked out? And I've heard stories where sometimes, especially with younger patients, and maybe it's changed now, but in younger patients, you're not supposed to get colorectal cancer. So oftentimes it could be a months-long journey until you actually get diagnosed with cancer, right?
Yes. So actually, most tumors that develop in younger people happen in the left side of the colon or the rectum. And the most common symptom that results from that is seeing blood in the stool. So bleeding in the stool is by far the most common presenting symptom, as well as a change in bowel habits. So new diarrhea, new constipation, or a thinning of the caliber of your stool. But abdominal pain and unintentional weight loss can also be seen. And you might all be thinking the problem with that is that these are also nonspecific specific. And when it comes to a younger person having these symptoms, it is much more common that a benign cause is the reason. But there needs to be increased attention to young people presenting with these symptoms because, as you mentioned, there are significant delays in diagnosis for young people with colorectal cancer.
Shuji, can you talk about the research? I mean, if we know, there's a rise in early onset cancers. I mean, what can research help us? Beyond lifestyle changes, better detection. Can research help us better understand what's happening?
So you mentioned about some specific pathologic changes or molecular changes in early onset cancer, and actually research on those specific factors help a lot. First, that can give us pathogenic insight, etiologic insight, and also we can link to risk factor much better if we can pick a very specific subtype of tumor. We can link risk factor better, and then we can find new risk factors too. Recently we find some of the, I don't mention what, but it's an early life factor in the baby. When we get in baby, can be a risk factor for cancer decades later. So those are picked up by specific molecular changes or some microenvironmental changes too. In that case, actually, we can detect some specific bacteria, called E. coli, with toxigenic E. coli. That can be linked to risk factors. So that can help us identify new risk factors. So research definitely help.
Tricia, I think when we talked earlier, you talked about the difficulty of studying young people, right? And that they're not a lot. It's actually hard to study cancer in children, right?
Yeah, that's absolutely right. These studies are incredibly difficult to do. They require a huge number of resources and a lot of investment early on longitudinally, right? And so some of the best studies actually have come out of Harvard. Like, for example, the Nurses' Health Study is where we follow people over time, decades, and we're tracking biospecimen, we're tracking lifestyle factors. You have to invest in these decades in advance. You also, decades in advance, often have to know the right question to ask in order to track for it. Like, for example, if I asked any of you in the room right now, how much sunlight, how many hours of sunlight did you get when you were 7 years old? What about when you were 8 years old? What about 9? Like, this would be very hard to quantify now, decades in the past. But some studies have been doing these kinds of studies, but they're limited. They take a lot of resources. Some of the funding to those studies have come under fire lately. And so it's really important that we invest and think about doing that the right way. And I'll also certainly defer to Kimmy, who's been involved in a lot of these studies.
Yeah, no, I absolutely agree with you. The ideal study is to follow somebody from actually in utero to infancy through childhood, adolescence, all the way into adulthood and monitor them to see if they develop cancer. But studies like that are really hard to do, expensive, and honestly, they take too long, and we need answers sooner than that.
I remember being asked to be part of some research study, and I was like, "Oh, this is a big commitment." I have to do something 3 or 4 times a week, and then once a month, it's like half an hour. It's like, I don't know. I feel bad.
But as I mentioned, every tumor develops many years over decades. So we have to assess risk factors. Really, we need to follow people long enough, many people, tens of thousands of people, long enough, decades, to get exposure data, what we call exposure risk factor data.
There was another good question from the audience. I was thinking about this too. I think, Tricia, you had mentioned about the different kinds of screening. You don't have to just do the colonoscopy. You can do stool testing. But the question is, what about, I guess, I'm not sure if disparities is the right word, but like maybe effectiveness, is the colonoscopy the gold standard? And so if I do the stool testing, it might not detect the cancer as well as the colonoscopy.
Wonderful question. So let me start by answering that by saying the best test for you is the test that will get done, right? So if you are just not going to get the colonoscopy for any number of reasons, get the stool kit. That's easy. You mail it to your house, you mail it back. The reason gastroenterologists like myself really urge people, if you're able to get the colonoscopy, is because colonoscopies not only detect cancers, they can prevent cancers because we can find those early polyps before they develop in cancer. Right then and there, we can take them out. And then we can kind of risk stratify you based on what those polyps look like, how many you had, and say, okay, you should come back earlier than the next 7 to 10 years. We're going to look for them again, make sure they haven't grown. So that's why we really urge colonoscopy. That's why it's the gold standard. The stool kit is actually very effective. Like, it does, in terms of detection, it can detect cancers and precancerous polyps. If that's positive, you need to get a colonoscopy to follow it up and take it out. The concern just is that with the colonoscopy, or the good thing about the colonoscopy is that you can also catch them at that earlier stage and then sort of risk stratify you.
Kimmy, I wanted to go back to a point that you made earlier about how treatment is different for younger patients with cancer. And I found this in my own reporting in interviewing young cancer patients. You know, I was struck by, you know, let's say a woman in their 20s, right? She's facing this stage 3 cancer diagnosis, whether it's breast cancer or colorectal cancer. And she's not thinking about if I will live or die. She's thinking about, I'm going to live, and I want to have children, and I want to breastfeed. You know, so if you're going to give me all these treatments, they're weighing whether or not to have a mastectomy or if that will affect their breastfeeding. And so I found that extraordinary. And I was just wondering, how as a doctor, how that must change the way you deal with patients, because our impression of cancer is that doctors will, you know, do everything right they can to get rid of the cancer. But now it seems it's a little bit different now, the way that doctors treat cancer.
I think it is. And that is one of the main goals of the center that we started, is to really treat the patient holistically and not just focus on the medical, the surgical, the radiation treatments that are indicated to help the cancer, but also to help the person going through it live as the best quality of life possible during the treatment. And this is hugely important because, unfortunately, most of our young patients with colorectal cancer have stage 4 and incurable cancer. So one of our major goals is to help them have the best quality of time, quality of life left in the time that they do have with their family.
More good questions for the audience. I don't know if they're coming virtually or in person, but can you guys speak to the existing treatment options for colon cancer? So you have it. What are the treatments? Do we have enough? Is there? And so I guess talk about that. Like, has that evolved or advanced?
There have been significant improvements in the treatment of colorectal cancer over the last few decades. And the treatment really depends on what stage of colorectal cancer you are diagnosed with. So stage 1, 2, and 3 are considered localized cancers that are potentially curable. And certain stage 4 patients who have metastases limited to one organ, for example, may also be considered curable. When you have a localized cancer, surgery is usually part of the treatment, and chemotherapy and radiation therapy for rectal cancers may also be part of that treatment algorithm. When you get to stage 4, it's mainly systemic chemotherapy that is the mainstay of treatment. But there have been huge advances in targeted therapies that really target a certain mutation in tumors, and in immunotherapy for treatment of a rarer subtype of colorectal cancer that has really improved survival rates.
All right, I don't want to scare everybody about cancer, and because one of the things that I learned in reporting about cancer is that in the last 30, 40 years, we made incredible strides in cancer treatment and the number of people who survive with cancer. And Shuji, maybe you could talk about this, because it goes to how we have to change the narrative of how we think about cancer. We can't think of it as a death sentence. We have to think about something that we should look for and we should get treated for, and not just ignore it and not think about it.
I think, the best way to rethink about cancer is a environmental disease. That means what we do, what we eat, what everything surrounding us influence cancer biological behavior too. So improving lifestyle, before even cancer diagnosis, but even after cancer diagnosis, can improve outcome, and many studies show that too. And also, the cancer is a microenvironmental disease. What means, tissue, local, small environment. That's also linked to external environment too. So we can change our behavior, and then we can, change tumor behavior. And then basically we can survive. And also, as I mentioned, tumor develop over decades. So when you get the cancer today, it's a result of everything you did over your life, since you were born or even before you're born. What you did, what your mother did and what your father did, imprinted into your genome, epigenome, and then goes into cancer genome, epigenome too. So that's kind of hard to address. But what we can do is we can improve our next generation's outcome, our kids' outcome. So we have to change mindset, in my opinion.
I also think we need to change the way we think about survivorship, right? A survivor is not just somebody who's gone through treatment, completed their surgery, and is now on monitoring. But stage 4 patients are also survivors. And we heard earlier today that obesity is a chronic disease. And I think more and more cancer will become a chronic disease as well that just requires treatment over a long period of time. And so I do think we need to reconsider the definition of survivorship as well when we think about cancer.
And Tricia, I know you get a lot of questions about this when you're writing your Washington Post column, but people a very common question must be, how can I prevent getting cancer? What can I do, or especially with colorectal cancer? What are the steps I need to do, specifically?
Yes, very common question. And I write about this often. I think in decades or generations past, the things we thought about for cancer were our genetics, which we don't have any control over, and smoking, which we are doing less and less of as a country. But there are these other risk factors that have now emerged for colorectal cancer and other cancers where I think we do have a little bit more agency. So kind of the big 5 that I tell people about, make these small changes, would be 1, alcohol, cut down the alcohol, right? And we are fighting against decades of dogma that used to say drinking 1 or 2 glasses of wine a day is healthy. It's like good for your heart. It might even help mortality. That is not the case, right? For cancer, when we're talking about cancer, there is no safe amount of alcohol. Red and processed meats. And I'm saying red meats, hard stop, processed meats, hard stop. There's good data for both of these things, and red meats are really ingrained in our diet, so this is a really hard message to hear. Ultra-processed foods is the third thing, and you alluded to this and have done a lot of studies on this, but ultra-processed foods cause microinflammation, they disrupt the microbiome, they've been closely linked to colorectal cancer specifically. Sugary beverages. We know that sugary beverages aren't good for our metabolic health. I don't know that a lot of us are making that connection as strongly as we should be to cancer risk. And we've been drinking more and more of these in our childhoods, teenage years. That's been on the rise. And it's been shown to be linked to colorectal cancer. And then lastly, I think we need to break up with our desk chairs. We got to break up with our couches, because sedentary lifestyles, as you talked about, that is an important risk factor for early onset cancers. There was an important study from the Nurses' Health Study here at Harvard that showed that the number of hours you spend watching TV each week is linked to cancer. And it's not just about weight gain. It's not just about BMI. Sedentary behaviors, even if you have a BMI within the normal range, you have to be active and move. So I focus on those 5 when I'm talking to people, because sometimes thinking about all of this sort of what people are calling toxins, chemicals in our environment, that can feel really overwhelming. Like you don't feel you have as much agency to control, right? And microplastics, big part of this conversation. And by the way, I don't heat my food in plastic anymore for this reason and like other reasons. But when I'm trying to make small changes in my life, I think plastics are everywhere. I know what I'm putting in my body. I make conscious choices about that every day. So those are the things I focus on.
All right, we've run out of time. So thank you to our all-star panel, Doctors I'm going to call you doctors now, Doctors Ng, Pajricha, and Ogino. And now we're going to have some closing remarks from another doctor, Dr. Raj Hazarika from Point32 Health.
Good afternoon, everyone. First of all, thank you to the Boston Globe for this terrific event. We're very proud to be associated with it. Thank you to the audience for coming and listening, and of course to this terrific panel for this very important conversation. So I really liked the narrative of thinking about how we should change our narrative on cancer as a whole. It's changing more from a terminal illness to one that we can live with. And that's great. We have made incredible advances over the last few decades with improved outcomes and improved life expectancy. So really good things to think about. It's great to hear about the observational studies that are ongoing to identify the risk factors for the increasing incidence for certain cancers like colorectal cancer. And once we know what those are, that's when we can actually change those risk factors. If we don't know what they are, it's hard to do that. I'm actually, I've got some training in epidemiology, so this field is sort of near and dear to my heart. I think the conversation on prevention, on screening is terrific. To know that there are many ways of screening, and there might be some trade-offs, but as you said, the best test is the test that you'll get. So I think that this is a very, very important topic. We really need to understand why this is happening. I will also just add a couple more things. There are potentially some cultural factors which may be playing a role here. And, just as we talked about red meat over here, there might be other things that are potentially increasing risk factors. So we have to, again, approach those carefully and sensitively and make sure that those messages come across. I'm of Asian descent, Indian descent, and I know the deficiencies in our traditional Indian diets for a host of conditions. So I know how difficult some of those changes can potentially be. Lastly, I'd just like to, bring a couple of seconds of attention onto an important sort of topic, which we all should be just aware of. But from a public policy standpoint, oncology care is sort of the number one cost bucket. Cardiometabolic disease, which used to be, and hoping that will be addressed, in coming decades, given the advent of other medications such as GLP-1s and others, is sort of like we have a good roadmap for that. But oncology, just because of a host of other conditions and some due to very good advances, is a big sort of cost category, and we just need to be aware of that from a public policy standpoint, because ultimately, for the cost of care, we're all responsible for it. Each household in America is contributing to that either through premiums or cost shares or through taxes. And so, we definitely need to come together collectively and make sure that everything is sustainable in the long run. I'll end there. I'm really looking forward to the next conversation on young health changemakers. I'd like to request everyone for another round of applause to a terrific panel discussion we had today.